A lot of people over 60 think the safest thing they can do for their heart is get more testing. More scans, more checkups, more screening, more reassurance. But after more than 2 decades in cardiology, I can tell you something that makes many families very uncomfortable at first. Some of the medical checkups people chase after 60 do not protect the heart. They confuse the picture, trigger fear, drain money, and sometimes push patients straight into procedures they never truly needed. And when I get to checkup number 1, the one I would personally refuse unless something clearly changed in my symptoms, you're going to understand why so many heart patients end up on a medical treadmill they never meant to step onto. I'm Dr. Sandra Whitemore, and today I want to talk to you the way I talk to my own patients when the exam room door closes and the real conversation begins. If you want honest heart-saving guidance for your later years, please subscribe now so you never miss the next video. Because if you already have heart disease, or you've been told you're at high risk, your goal is not to collect the most tests. Your goal is to get the right care at the right time for the right reason. There is a huge difference between life-saving testing and fear-driven testing. And if you don't know that difference, you can end up chasing shadows while the things that truly matter, blood pressure, medication review, walking tolerance, kidney function, sleep, diet, and symptoms, quietly get ignored. Let me start with a man named Frank, a 72-year-old retired firefighter from Columbus, Ohio. Frank had a stent placed years earlier and was doing pretty well. He was walking his dog every morning, taking his medications, keeping his blood pressure in a decent range, and he had no new chest pain, no new shortness of breath, no fainting, nothing dramatic. But he believed that being responsible meant asking for every heart test he could get once a year. One test led to another. An imaging result looked a little questionable. Then came another scan, then a specialist visit, then a procedure discussion. By the time he got back to me, he was terrified, exhausted, and convinced something terrible had been missed. What actually happened? Nothing dangerous had changed in his heart. The testing cascade had changed, and that cascade nearly hurt him more than his coronary disease did. That word matters more than you may realize, cascade, because one unnecessary test rarely stays one unnecessary test. It becomes a follow-up image, then a contrast study, then a consult, then maybe a catheterization, then maybe a hospital bill that shows up just when you were trying to help your granddaughter with college books or cover rising grocery costs. This is why I need you to hear me very clearly. The 5 checkups in this video are not bad tests. In the right situation, they can be excellent, even life-saving. But as routine reassurance tests in stable heart patients over 60, they are often overused, misunderstood, or pushed long after the information they provide stops being useful. And that is where smart medicine turns into reflex medicine. Before we get to number 5, I need to place one guardrail around this whole conversation. Because this part can save lives too. If you have new chest pressure, worsening shortness of breath, passing out, racing heartbeats that don't settle down, swelling that is suddenly getting worse, one-sided weakness, trouble speaking, or a sudden change in exercise tolerance, that is not the moment to say, Dr. Whitmore said, don't get tested. No, that is exactly when you need evaluation. These are the 5 medical checkups I would not get as routine screening when I'm stable, symptom-free, and already under active heart care after 60. That distinction matters. Because wise medicine is never about doing nothing. It's about not doing the wrong thing while pretending it's prevention. So let's begin with checkup number 5. And this one catches a lot of good people because it sounds so reasonable, so harmless, so preventive. Checkup number 5 is a screening carotid artery ultrasound when you have no stroke symptoms and no mini-stroke symptoms. I'm talking about the test some people get at church health fairs, community screening vans, or as an add-on at a private clinic because they were told, you're over 60, you have heart disease, let's check your neck arteries just in case. On the surface, that sounds smart. The carotid arteries feed the brain. Blockages can be linked with stroke. So why not look? Because in people without symptoms, the test can create false alarms, and those false alarms can open the door to more testing and more procedures without proven benefit. I think about Elaine, a 74-year-old widow from Tulsa, Oklahoma. Elaine saw an ad for a vascular screening bundle that promised peace of mind. She had coronary artery disease, controlled diabetes, and a deep fear of stroke because her sister had 1 year earlier. So, she paid out of pocket for a carotid ultrasound even though she had no speech trouble, no weakness, no history of TIA, no warning signs at all. The report came back concerning. That one word wrecked her sleep for 2 weeks. She was certain a devastating stroke was around the corner. Then came more appointments, more imaging, more anxiety. In the end, the finding did not translate into a meaningful intervention that improved her outcome beyond what she should already have been doing, taking her statin, controlling her blood pressure, staying on antiplatelet therapy when appropriate, not smoking, and managing diabetes. Here is what most people miss, and it's so important. A screening test is only worth doing when it reliably identifies a problem early and when finding that problem leads to a treatment that clearly improves outcomes. In asymptomatic carotid screening, that chain breaks down. The disease causes only a small share of strokes. The screening can produce false positives, and the procedures used after a positive result can carry harms of their own. In other words, the test can discover something that sounds scary but doesn't help you live longer or better once all the downstream consequences are counted. That is why major preventive guidance in the United States has recommended against routine screening for asymptomatic carotid artery stenosis in the general adult population, even though risk rises with age. The logic is not emotional. It is outcome-based. Now, does that mean carotid imaging is never useful? Of course not. And this is where nuance separates good medicine from bad internet advice. If you've had stroke symptoms, a transient ischemic attack, new neurologic complaints, or there is a very specific clinical reason your physician is worried, that is a completely different conversation. But if you are a stable heart patient over 60 and someone is trying to sell you a neck artery screening just because it sounds preventive, I would pass. I would rather spend that energy on the things that actually move stroke risk in the real world. Keeping your pressure controlled, taking cholesterol treatment seriously, walking consistently, sleeping well, managing blood sugar, and making sure your medications still fit your kidneys and your age. That is boring medicine. It is also the medicine that works. Checkup number 4 is one that surprises a lot of caregivers and even some patients who've been in the system for years. Checkup number 4 is a routine yearly echocardiogram when you have chronic heart failure or known stable heart disease and nothing has changed. The echocardiogram is a beautiful test. I love echocardiography. It shows me the pumping strength of the heart, valve function, chamber size, fluid clues, pressure clues, so many useful things. But useful is not the same as automatically useful every year forever. If your symptoms are stable, your medications are stable, your exam is stable, and there's no management change being considered, repeating an echo on a rigid schedule can become little more than a ritual. And rituals in medicine feel comforting. But comfort and benefit are not the same thing. Let me tell you about Robert, a 76-year-old Vietnam veteran from Sarasota, Florida. Robert had heart failure with a reduced ejection fraction years ago, but he had done remarkably well on treatment. He knew his medications by heart, never missed a refill, checked his weight every morning, and called early when swelling increased. For 3 straight years, he was walking the same distance, sleeping flat, breathing fine, and staying out of the hospital. But every year, like clockwork, he was sent for another echocardiogram. Each time he became anxious for days waiting for the result, convinced some hidden decline was about to appear. Each time the report came back basically unchanged. And each time he asked me the same question: what did this one do for me? The honest answer in that moment was very little. There are times when repeating an echocardiogram is absolutely the right move. If a valve problem may be worsening, if your shortness of breath changes, if a murmur sounds different, if a device decision depends on updated pump function, if you're being considered for a therapy change, that's different. But for a clinically stable patient with chronic heart failure and no meaningful change in signs, symptoms, or management, a routine serial echo often does not add anything actionable. It gives the illusion of careful follow-up, while the real quality of care may depend far more on whether your blood pressure medications are at the right dose, whether your kidneys are tolerating treatment, whether you are retaining fluid, whether your sodium intake has crept up, and whether your walking capacity is slipping. Those are the details that often predict trouble before a pretty picture on a screen does. This is one reason I always tell heart patients over 60 to ask a very simple question before any repeat imaging. What will this test change? Not, could it find something? Because almost any test can find something. Not, wouldn't it be safer just to look? Because that's how overtesting sneaks in wearing a lab coat. Ask, what decision will change because of this result? If the answer is fuzzy, if nobody can explain how the information would alter treatment, then the test may be serving anxiety more than medicine. Robert did far better once we shifted his focus from annual imaging to symptom tracking, weight trends, labs, medication optimization, vaccines, daily walking, and early response to fluid changes. That is the kind of follow-up that keeps older heart patients independent. Now we come to checkup number 3, and this one is especially important if you already know you have atherosclerosis, coronary artery disease, prior stents, a prior heart attack, or a history of bypass surgery. Checkup number 3 is a coronary artery calcium score when you already have known clinical heart disease. This test has real value in the right setting. For somebody without a diagnosis, it can sometimes help refine risk and guide prevention decisions. But once you already know plaque disease is present, once the diagnosis has been established, the calcium score often stops being helpful and starts being redundant. It becomes like weighing yourself 10 times in an hour after you already know you're standing on the scale. The number may change your emotions, but it usually doesn't change the right treatment plan. I remember Nancy, a 69-year-old retired school principal from Scottsdale, Arizona. Nancy had a prior stent and was under excellent preventive care. She was already on cholesterol treatment, already working on her diet, already exercising, already getting blood pressure follow-up, and already very aware that she had coronary disease. Then a friend told her she needed a calcium score to see how bad it really was now. So she got one. The score was high, as you would expect in someone with established plaque. She panicked. She thought the number meant an immediate heart attack was about to happen. She came into my office pale, clutching the printout, asking if her arteries were basically cement. But the result didn't give me a new diagnosis. It didn't give me a superior treatment strategy. It mostly gave her a number to fear. This is the trap with certain tests after 60. The information sounds precise, but it may not be decision useful. In a person with known atherosclerotic cardiovascular disease, a calcium score does not usually contribute meaningful new guidance for treatment. You already know aggressive risk reduction matters. You already know LDL cholesterol management matters. You already know blood pressure, smoking avoidance, physical activity, diabetes control, weight, sleep, and medication adherence matter. The score can't tell you that more clearly than your history already has. And when older adults misunderstand the result, they may either feel falsely reassured by a lower-than-feared number or devastated by a high number, even though the medical plan should have been serious in either case. Numbers are powerful, but they are not always wise companions. I want to be careful here, because I do not want you leaving this video thinking calcium scoring is a worthless test. It is not. It can be useful in selected people who do not yet have known clinical disease and are trying to sort out prevention intensity. But if you already carry the label of coronary artery disease, prior heart attack, angina, stroke from atherosclerosis, or prior revascularization, using calcium scoring as a routine checkup can be like opening an umbrella indoors and calling that weather forecasting. It gives you a gesture, not a better outcome. What I would rather see in someone like Nancy is a serious medication review, a cholesterol target discussion, a blood pressure log, walking tolerance assessment, nutrition coaching, and a conversation about inflammation, sleep, insulin resistance, and stress. That is where the next heart event is actually fought. And now we move to checkup number 2, the one that has become incredibly popular with people who want certainty, people who are tired of waiting, people who think more imaging must equal better prevention. Checkup number 2 is the full-body CT screening package, or those executive scan bundles marketed to symptom-free adults as a way to catch everything early. If you are over 60 and living with heart disease, you are especially vulnerable to this marketing because you've already had one major health scare. So when someone offers a machine that promises to look everywhere at once, it feels almost irresponsible to say no. But this is exactly where older heart patients can get trapped. Because the body is full of harmless little findings, age-related changes, incidental spots, calcifications, nodules, and shadows that can look important before anyone knows whether they matter. Bill was 71 and lived outside Phoenix, Arizona. His son bought him an expensive executive wellness package after Bill's bypass surgery anniversary because the family wanted one big scan for peace of mind. Bill was feeling fine. He had no alarming symptoms, no unexplained weight loss, no new chest discomfort, nothing urgent. But the scan found a few incidental abnormalities. Nothing dramatic. A tiny nodule here, a little thickening there, one area the radiologist suggested correlating clinically. Bill didn't get peace of mind. He got months of callbacks, extra imaging, specialist visits, sleepless nights. His wife told me, "We paid for reassurance and bought ourselves a season of fear." And that sentence, I wish every older adult in America could hear it before signing one of those screening packages, because that is how these packages often work in real life. The problem is not that CT technology is bad. It is an extraordinary tool when you have symptoms, trauma, a defined clinical question, or a disease that truly benefits from targeted imaging. The problem is using a high-radiation, highly sensitive scan as a fishing expedition in healthy or stable symptom-free people. When you scan enough anatomy, you will find things. Some will be real but unimportant. Some will be ambiguous. Some will be false leads. Then come more tests, more radiation, more contrast, more biopsies, more cost, more anxiety. And the central question remains unanswered. Did the original scan improve how long you live or how well you live? For full-body CT screening in asymptomatic people, that benefit has not been established the way many consumers assume it has. And here's the part almost nobody mentions in the ad. The scan can also falsely reassure you. A normal full-body CT is not a magic shield. It does not prove your arteries are stable tomorrow. It does not mean your blood pressure is controlled. It does not mean your medications are optimized. It does not mean your future stroke risk is handled. It does not erase inflammation, unstable plaque, rhythm problems, kidney decline, sleep apnea, insulin resistance, or medication side effects. So you can end up with the worst of both worlds. A normal-looking scan that lulls you into complacency, or an abnormal-looking scan that sends you into a spiral, while the actual foundations of prevention remain untouched. Bill would have been far better served by targeted follow-up on cholesterol, exercise, blood pressure, and symptoms than by a machine looking for trouble everywhere at once. Now we arrive at checkup number 1. And if you are a heart patient over 60, this may be the most common overused reassurance test of them all. Checkup number 1 is the routine annual stress test, especially the imaging or nuclear stress test, when nothing in your symptoms or functional status has changed. Let me say that again because this is where so many people get emotionally hooked. If you are stable, if you're not having new chest discomfort, if you're not getting more short of breath, if your walking ability is the same, if there has been no meaningful clinical change, getting a stress test every year simply because that's what we do is not something I would personally sign up for. Not because stress tests are bad. They are extremely valuable when used correctly. But when used routinely in stable, symptom-free patients, they can create more noise than signal. So what would I do instead? This, to me, is the more important half of the video, because I never want to leave you with fear and no plan. If I were a heart patient over 60, I would invest heavily in what I call high-value follow-up. I would want a doctor who asks how far I can walk now compared with 6 months ago. I would want a medication review that catches duplication, side effects, dizziness, swelling, or bradycardia. I would want kidney labs and electrolytes when appropriate. I would want my blood pressure technique checked, not just my blood pressure number. I would want my cholesterol response assessed, honestly. I would want questions about sleep, fatigue, depression, appetite, constipation, ankle swelling, and adherence. I would want my care centered on how I function, not just how many images I collect. I would also keep a personal symptom record, and this is one of the smartest things older adults can do. Not a dramatic diary, just a simple log. Can I still make it up the driveway without stopping? Am I more winded bringing groceries in from the car? Did my weight jump 3 pounds in 2 days? Am I waking up breathless? Are my shoes tighter by evening? Has chest discomfort appeared during exertion that used to feel easy? Those small patterns are gold? They often tell us more than a reflex screening test. The heart usually whispers before it screams. But if you train yourself to notice the whispers, you and your doctor can respond early and intelligently, instead of waiting for a calendar-based test to stumble across something that may or may not matter. There's another question I wish every patient over 60 would ask before agreeing to a test, especially if you already have heart disease. Ask, if this comes back abnormal, what happens next? That question reveals everything. If the answer is unclear, if the next step would be another test, then maybe another, then we'll just see, that should make you pause. Ask, could this result be falsely positive? Ask, will this change my medications or my treatment plan? Ask, am I having symptoms that make this necessary, or am I just frightened? Fear is understandable. Fear is human. But fear is also one of the biggest engines of low-value testing in cardiology, and the medical system is not always good at slowing down long enough to separate fear from evidence. Let me bring Frank back into this for a moment, because his story matters. What finally helped him was not another test. It was understanding. Once he realized that stability had value, that not every year needed a new scan, that his quiet daily habits mattered more than chasing perfect certainty, he relaxed. His blood pressure improved. He started walking longer again. He stopped treating every twinge like a catastrophe. His wife told me, we got our life back when we stopped trying to scan our way into safety. I have never forgotten that sentence. Because so many older heart patients are not actually looking for medicine when they ask for these checkups. They are looking for safety. They are looking for a guarantee. And medicine, honest medicine, has to tell the truth. Sometimes the test does not give safety. It gives the illusion of control. So let me summarize these 5 checkups I would not routinely get after 60 as a stable heart patient unless there was a clear reason. Number 5, a screening carotid ultrasound when you have no stroke or TIA symptoms. Number 4, a routine yearly echocardiogram when your chronic heart condition and management have not changed. Number 3, a coronary artery calcium score after you already know you have clinical atherosclerotic heart disease. Number 2, a full-body CT screening package sold as peace of mind for symptom-free adults. And number 1, the routine annual stress test, especially nuclear or imaging-based stress testing when your symptoms and functional status are stable. None of these are evil tests. That's not the point. The point is that the right test at the wrong time can become the wrong care. And if you remember nothing else from this video, remember this line because it can protect you from years of medical overuse. Do not ask, what test haven't I had yet? Ask, what problem are we trying to solve? That one shift changes everything. It moves you away from fear-driven medicine and toward evidence-driven medicine. It protects your time, your wallet, your sleep, and in many cases your body from the downstream effects of unnecessary findings. It also creates a better relationship with your doctor, because now the conversation becomes thoughtful instead of automatic. Good cardiology is not about ordering more. It is about knowing when to stop, when to watch, when to optimize, and when to act quickly. Wisdom in medicine is not hesitation. It is precision. Now, I need to add one more warning, because some people hearing this will be tempted to swing too far in the other direction. Please do not use this video as an excuse to ignore symptoms. New chest pain is not probably nothing. New breathlessness is not just aging. A sudden drop in stamina is not something to brush off for 6 months. Trouble speaking, facial droop, sudden arm weakness, blacking out, or a racing heartbeat with dizziness deserves urgent attention. The smartest older patients are not the ones who avoid tests at all costs. They are the ones who avoid the wrong tests and seek the right evaluation without delay when their body changes. That is the balance I want for you. Not fear, not denial. Clear-eyed judgment? You have worked too hard to reach this stage of life to let unnecessary testing steal your confidence. You deserve care that is calm, targeted, and honest. You deserve a doctor who can say, we don't need that test right now, and make you feel safer, not abandoned. You deserve explanations that respect your intelligence. And you deserve to know that sometimes the most protective decision in cardiology is not adding another scan, but doubling down on the basics that keep hearts stable year after year. Take the walk. Take the medicine. Check the pressure. Watch the swelling. Protect your sleep. Speak up early if something changes. That is not flashy medicine. It is durable medicine. It is the kind that helps people stay in their own homes, hold their grandchildren, drive to church, travel, and wake up without constant fear. If this video helped you think differently about heart care after 60, do 2 things for me. First, subscribe to this channel because I'm going to keep giving you the kind of practical, evidence-based guidance that helps you avoid both neglect and overuse. Second, share this with someone who thinks more testing always means better care. It might spare them a lot of unnecessary fear. And I'd love to hear from you in the comments. Which of these 5 checkups surprised you the most? Was it the stress test, the calcium score, the yearly echo, the carotid ultrasound, or the full-body CT scan? Tell me below. I read those comments closely, and I use them to shape the next videos for this community. Take care of your heart, protect your peace, and I'll see you in the next one.